the class, and I am not new to this platform basically. So let's start. So the today's topic is chronic liver disease as cirrhosis and its complication. Cirrhosis is basically a pathological entity defined by diffuse fibrosis with replacement of the normal liver architecture by nodules. Basically, the liver undergoes fibrosis. The rate of progression of CLD to cirrhosis may be quite variable. That depends on the type of etiology, the type of exposure this etiology is keep on having. Like if the patient continues to drink alcohol, the cirrhosis will progress pretty fast. If the patient is abstinent, of course, the rate of progression will be slow. Similarly, in hepatitis B, if you are given antiviral, or hepatitis C, you are given direct-acting antivirals, the rate of progression may slow down. But if these things continue, it may be occur. Now, what are the causes of cirrhosis? Cirrhosis causes, first is viral, you can say, hepatitis B virus, hepatitis C virus, hepatitis D virus. D virus in combination with B virus. The virus causing acute hepatitis like hepatitis A and E doesn't cause cirrhosis. Hepatitis E can sometimes cause cirrhosis in immunosuppressant people, like patient having renal transplant. They can have a cirrhosis due to hepatitis C. But hepatitis A is not known to cause cirrhosis, and hepatitis C causes cirrhosis only in exceptional circumstances. Okay. Next comes etiology like autoimmune. Patient can have autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis. PBC earlier was terminology was primary biliary cirrhosis. Now it is primary biliary cholangitis. Just the change of name. Most common causes in our setup all over the world is alcohol. 10% of chronic alcoholic develop cirrhosis. Arsenic can also cause. Metabolic, Wilson's disease is the most common metabolic disorder which we see as cirrhosis. Then hemochromatosis. Then in childhood, glycogen storage disease, alpha-1 antitrypsin disease. NASH can also be cause cirrhosis. NASH is the most common, one of the most emerging cause of cirrhosis that we are dealing now. Earlier, it used to be called as cryptocirrhosis, but nowadays in India, the lean NASH is also very common cause of cirrhosis. Lean NASH means where the person is not obese and still you have the fatty liver and it develops state of hepatitis and then ultimately cirrhosis. Biliary etiology, like there is a stone there for long duration causing obstruction. With the chronic obstruction, secondary biliary cirrhosis can develop. Vascular etiology like Budd-Chiari syndrome, chronic calcific pericarditis, they keep on congested of the liver because the liver ultimately drain into the inferior vena cava, which in turns develop and drain into the right side of the heart. So basically that can cause congestion and cirrhosis. Genetic like cystic fibrosis, lysosomal acid lipase deficiency, these can cause. Iatrogenic like biliary injury, somebody has ligated the bile duct, or like some drugs, methotrexate, given for long term. Like in rheumatology, if you give high dose methotrexate for long periods, that can result in cirrhosis. Now, pathogenesis. Whenever this injury occurs, this Kupffer cell, which is present in the space of this between the epithelial cell and endothelial cells, that get transformed into the hepatic stellate cell. Kupffer cell are a type of a macrophages. They get transformed into the hepatic stellate cell, which upon the activation turns into a myofibroblast. This myofibroblast release the matrix, then the proteases act, and there can be fibrosis formation. Some amount of fibrosis can be resolved, but when the injury is continuous in nature, this fibrosis will keep on occurring and nodule will form. That is known as cirrhosis. How you diagnose cirrhosis? It is by a combination of clinical, laboratory, and imaging features that you can make a diagnosis of cirrhosis. Gold standard is our liver biopsy, where you will demonstrate fibrosis and nodule formation. Now, this is the clinical slide, basically, which all of you will be aware of. Like in MBBS, I still remember our professor used to tell us 5 signs of cirrhosis in eye, tell us 5 signs of cirrhosis in the hand. These are given in Kundu, Davidson, everywhere. So basically, you can have jaundice, you can have KF rings, you can have this even like cyanosis, cyanosis usually occur in cirrhosis in hepatopulmonary syndrome वगैरह में होता है. Then on skin, spider navy, loss of axillary air, gynecomastia, tendinopathies, leukonychia, pallor, palmarythma, Dupuytren contracture, astraxis, hepatomegaly, ascites, caput-medusae, splenomegaly. All these signs will be seen. These you are well aware of. Imaging, of course, you will do a ultrasound that will show a cirrhotic liver. That is a small liver usually with nodule formation, dilated portal vein, and splenomegaly. So that will say it is a cirrhosis with portal hypertension. You may find ascites also. A CT scan. CT scan in usually is not the first choice, but whenever you are suspecting any complication like hepatocellular carcinoma, you always get a triple phase CT scan. Hepatocellular carcinoma is one of the few cancers which you can diagnose specifically on imaging. There is no need to do biopsy. Usually in all malignancies, you get to do a histopathological biopsy. But hepatocellular carcinoma, you can diagnose straight away on imaging, usually a triple phase CT or a MRI, because it is so specific on its finding. Like there is a washout, there is arterial and phase में enhancement मिलेगा, and there will be washout of the venous phase. So in those cases, we get a CT. Transient elastography, nowadays fibroscan is almost there in almost all hospitals, where you can measure the liver stiffness. More than 14 kilopascals suggests cirrhosis, with greater than 21 kilopascals associated with portal hypertension in complication. MR elastography is also available. Biochemical, one of the first signs to develop is a low platelet count. Whenever you see a patient, okay, his platelet count is low, that one of the investigation you should order is a ultrasound abdomen to look for the cirrhosis or portal hypertension. Because of the splenomegaly, the hypersplenicism start occurring and the platelet count comes down. Then APRI index, AST platelet ratio index, these are also available nowadays, where you can diagnose cirrhosis. But many patients who are having cirrhosis, they start, first sign to appear is usually low platelet count. Now, natural history of the cirrhosis. Cirrhosis is usually in the initial stage is a compensated cirrhosis, means usually doesn't have any complication. But 5 to 7% of compensated cirrhosis decompensate every year. Decompensation means there is some complications like ascites formation, like there is jaundice, there is a renal injury, there is hepatic encephalopathy. All these complications which occur, that is known as decompensation. Patient bled, upper GI bleed has occurred. Means decompensation means other than their liver, other organs are also having uh, means effect. So compensated cirrhosis, where we say we divide into stage 0, 1, 2. Like stage 0 means where there will be no varices on endoscopy, there will be mild portal hypertension. LSM liver elastography will usually be more than 15 but less than 20. HVPG, I will discuss HVPG also, hepaticovenous portal gradient, that will be more than 5 but less than 10. Stage 1, there will be no varices but clinically significant portal hypertension. Clinical significant portal hypertension means there is LSM more than 20 and HVPG is more than 10. Stage 2, you develop the varices. That is also basically clinically significant portal hypertension. If you are finding varices, no need to do HVPG or LSM. Stage 3, patient can bleed. Stage 4, we say it is first non-bleeding decompensation. Stage 5, second decompensating event, and after that stage 6 is late decompensation or end stage liver disease. In between, the patient can have an acute injury, and that patient can straight away land from stage 0 to stage 6, that is known as acute on chronic liver failure. It has a very high mortality and can lead to death. Like the patient is having a alcoholic cirrhosis, patient continues to take on alcohol, develop alcoholic hepatitis, and lands into, he was a stage 0 patient and lands straight away into the stage 6 ACLF. So transition from compensated to why this thing is involved. Compensated cirrhosis can survive up to the 12 years. Once the decompensation occurs, the median survival is only 2 years. And stage liver disease is usually 3 months to 6 months maximum. Now, scoring system. Most common scoring system which was used initially was this child book classification. That consists of 5 this things: encephalopathy, ascites, bilirubin, albumin, PT, INR. So it is divided into 0, 1, 2, 3 points are given, and child A class is usually 5 to 6 points, child B 7 to 9, child C 10 to 15. But nowadays better scoring system is now available, that is known as MELD, model for end stage liver disease. MELD initially was developed by Indian Dr. Patrick Kamath in his works in Mayo Clinic, and it was developed for TIPS. TIPS is basically transhepatic, transjugular intrahepatic portovenous shunt. So to see the response of TIPS in some patients, but this is a computer generated algorithm, consists of 3 values you have to remember: bilirubin, INR, creatinine. So maximum score what we take is 4. Nowadays the better score is MELD sodium, where you include the MELD plus sodium also to prognosticate the patients. So 3 month survival for MELD in each patient is basically given by this. Here you can see the patient having high MELD, means 40 or more, has 70 to 100% mortality in next 3 months. If it is above 30, 50 to 75% mortality. So very high mortality if the MELD is very high. 50% mortality around 20 to 29, means 20 to 45%. So MELD can predict the disease thing. Now, what are the complications of cirrhosis? First complication, of course, is the portal hypertension, which we see most commonly. It manifests as ascites and variceal bleeding. Then there can be malignancies in the late stage, like hepatocellular carcinoma first, and then sometimes cholangiocarcinoma or mixed type of hepatocellular and cholangiocarcinoma. Bacterial infections, most common is spontaneous bacterial peritonitis in this group, but patients can develop all kind of pneumonias, UTI because of low immunity. Cirrhosis is a immunosuppressed state. Then cardiopulmonary disorders like hepatic hydrothorax, hepatopulmonary syndrome, portopulmonary hypertension, and cirrhotic cardiomyopathy can also develop. Alcohol, etc., can cause alcoholic cardiomyopathy also. Then GI disorders, GI bleed. It can be a variceal bleed. Usually in cirrhosis, we find the cause of bleed as variceal bleed, but non-variceal bleed sometimes can also occur in these patients. Protein-losing enteropathy, venous thrombosis. Though remember this thing, INR is usually raised in cirrhosis, but cirrhosis is always a pro-thrombotic state. Even if there is a coagulopathy, it is a pro-thrombotic state. Okay, so many times we see the INR in the range of 1.6, 1.7, but still the patient will develop thrombosis like portal vein thrombosis, etc. Renal disorders like hepatorenal syndromes and other causes of AKI can occur. Metabolic disorders like adrenal insufficiency, hypogonadism, malnutrition, osteoporosis. Patient can have depressions, hepatic encephalopathy. Patient has anemia, hypercoagulability, I told you earlier. Hypersplenism is pretty common. As I told first, one of the first things to appear is low platelet count, impaired coagulation, erectile dysfunction, fatigue, muscle cramps. All these are complications of cirrhosis. We'll discuss not all, but because there are so many, if we discuss everything, it consists of 3 years of DM hepatology course. Almost 2/3 part is cirrhosis and its complication, and it's 1 hour for you. So how you manage a decompensated cirrhosis? So first, treat the etiological factor, treat the key pathogenic factor. If the patient is taking alcohol, starts the patient for consult the patient for abstinence of alcohol. That is the most important thing you can do. If patient is having hepatitis B, high DNA load, having cirrhosis, starts the antiviral. Hepatitis C, treat the hepatitis C. These are one of the Wilson's disease you can treat. So these are only the few causes where we can have treatment. Some patients we don't have any treatment also. Management of specific complications, if there ascites, refractory ascites, hepatic hydrothorax, hyponatremia, GI bleed, bacterial infection. This you have to identify what are the complications of the cirrhosis and manage accordingly and make your plan for the patient. So management should be aimed to prevent progression, not only treat the complication. Cirrhosis progression directly we can't stop as such, but we can slow down the progression at least. Two alternative approaches can be taken. First, suppress etiological factor and target key factor in pathogenesis. Now, first is portal hypertension and variceal bleed. Now you see this diagram, very important diagram. This is the portal vein which is formed by the splenic vein and the inferior mesenteric, superior mesenteric vein. Inferior mesenteric vein meets into the splenic vein. So SMA and splenic vein forms the portal vein. Then portal vein goes to the liver. Portal vein basically takes blood from whole of the gut. Almost whole of the guts send its blood to the liver. From the liver, it divides into the left and right portal vein, and then it went to the sinusoids, and then three veins are there: right hepatic vein, middle hepatic vein, and left hepatic vein. These drain all the segments of the liver and drain into the inferior vena cava. So this is the diagram. So whenever there is a cirrhosis, there are portal hypertension develops. Portal hypertension can be of three types basically. It can be pre-hepatic region, it can be hepatic region, or it can be post-hepatic region. Ascites develops when only there is a raised HUPD. Pre-hepatic region occurs in like EHPVO, which we see portal hypertension in absence. Portal hypertension can occur in absence of cirrhosis also, like in pre-hepatic region. NCPF हो गया, EHPV हो गया, extrahepatic portal vein obstruction that occurs in the first decades of life, where you have portal vein thrombosis and then cavernoma formation. You have huge splenomegaly. NCPF also, you get huge splenomegaly, portal hypertension. The patient bleed, but they don't decompensate. So this is a diagram showing the this thing is the hepatocyte stellate cell. You see, I told you earlier, this activation of stellate cell forms the collagen deposition in the space of Disse and cause the fibrosis, and the sinusoidal lumen ultimately contracts. Like this was so large here, sinusoidal lumen, now it contracts. Whenever there thing is this thing contract, the pressure which the blood is coming, like in between slide, whenever there is contraction in the sinusoids here, pressure in the portal vein increases. The size of the portal vein start increasing. Thus, because of the back pressure, the spleen size also start increasing. Whenever the spleen size start increasing, it start engulfing the platelets and later the RBCs and WBCs also. So thrombocytopenia usually occur. So these are the causes of portal hypertension: prehepatic portal vein thrombosis, splenic vein thrombosis. If there is isolated splenic vein thrombosis, we call it as left side portal hypertension. Otherwise, portal vein thrombosis can occur EHPV. Then intrahepatic causes, maybe there are three types: pre-sinusoidal, sinusoidal, and post-sinusoidal. Pre-sinusoidal usually doesn't cause ascites as such. Idiopathic portal hypertension, PBC, sarcoidosis, schistosomiasis, sinusoidal cirrhosis, all kind of cirrhosis basically. Sinusoidal is basically cirrhosis. Post-sinusoidal is sinusoidal obstruction syndrome. Post-hepatic, of course, you can have Budd-Chiari syndrome. Budd-Chiari syndrome is the older terminology. Now we call it as HVOTO, hepatic venous outflow tract obstruction. So all of these things are now known as HVOTO. Constructive pericarditis, inferior vena cava obstruction, right side heart failure, severe TR, all these can result in this thing. So whenever the pressure in the portal vein increases, like when the traffic on the road is so high, people start taking the alternate routes. So the blood will also start taking the alternate routes and collaterals start forming. So the collaterals can form into the esophagus, into the stomach wall, into the near the umbilicus, captus medusae, rectum, and all these things. Now, when the collaterals are formed, they are not the proper veins. So, when the pressure increases, they can rupture also. The most common site of rupture is the esophageal varices. Ectopic varices, like if it occur in duodenum or rectum, they rarely rupture. But most common site of rupture is the esophageal varices. So, esophageal varices rupture and there is a bleed there. Portal pressure is the most important factor in both rupture and severity of bleed. Once the bleed occurs, portal pressure comes down, usually sport stops spontaneously. You give medications to lower down the portal pressure also. Remember, it is not a emergency to get a upper GI endoscopy at that time itself. First thing, you have to stabilize the patient whenever the patient come, like you will be doing your internship, patient will be coming with upper GI bleed in the emergency. नहीं नहीं इसको अभी यहाँ पे एंडोस्कोपी अभी रात को नहीं होती, refer to somewhere else. You don't get the endoscopy done immediately. It may be done within 12 to 24 hours. First thing you have to do is stabilize the patient. ठीक है, see his hemodynamic status, because most of the bleeds stop spontaneously unless the pressure is very high. So stabilize the patient, maintain the hemoglobin around 8. We don't say that you increase the hemoglobin level to 10 or 12 because that will further increase the portal pressure, and give the drugs to reduce the portal pressure. So this is one of the second most decompensating event, and it is a severe and immediate life-threatening event. So you calculate the HVPG, hepatic vein pressure gradient. So it calculated from portal pressure minus hepatic vein pressure gradient. What we do basically during HVPG, we calculate the hepatic veins. From the hepatic vein, we puncture and put the catheter in the portal sinusoids. There we block and calculate the portal pressure and the hepatic vein pressure. So hepatic vein, we calculate HVPG by wedged hepatic vein pressure minus free hepatic vein pressure. Wedge means once you inflate the balloon, then you will see the pressure, how much it is, then free hepatic vein pressure. So it is usually around 4 mm of mercury. So more than 5 mm of mercury, we call it as portal hypertension. So HCPG is not a clinically very useful test. It is invasive also, where you have to calculate through the jugular vein, internal jugular vein. But sometime when the cause of cirrhosis or portal hypertension, cause of portal hypertension is not known, you can measure the HCPG. We can also do a transjugular liver biopsy also many times while doing the HCPG. So when both of the things are planned, you can do it. In prehepatic portal hypertension, HCPG is normal. Pre-sinusoidal also it will be normal. Sinusoidal, the wedge hepatic vein pressure is increased because, and then HCPG will be increased. Post-sinusoidal also it will be increased, but post-hepatic both are increased, so it will be normal. So HVPG value, if more than 10, there are formation of risk of formation of varices. More than 10 also means the patient can clinically decompensate, also means he can have ascites also. If you have risk of hepatocellular carcinoma, more than 12 means there is a risk of variceal bleeding. More than 16 means risk of death. More than 20, if the patient comes and bleeding, the patient can have a treatment failure also and increase mortality. Upper GI endoscopy should be done in all cirrhosis. You see, if there are no varices, repeat the endoscopy in next 2 to 3 years. If there are large esophageal varices, consider HVPG, or you can straight away give the, if the patient has not bled, beta blocker or carvedilol also is now the, carvedilol has recently last 1 or 2 years has replaced beta blockers, considering their side effect also, because beta blockers are now prescribed in a therapeutic window. You can't prescribe it too early, you can't prescribe it too late. Carvedilol is now a better choice. You can give that, and then you can see there whether the HUPG has improved or not, but that is more of a research work rather than patient benefit. You can see clinically, if you are giving beta blocker, the heart rate is decreasing by 25%. That is sufficient enough to decrease the portal pressure. If the patient is contraindicated to take carbidiol or beta blocker, then you can perform the variceal band ligation also. For small esophageal varices, you can repeat the endoscopy in 1 to 2 years. If the patient has bled from the esophageal varices, first, as I told you, you should resuscitate. Give agents to decrease the portal pressure like octreotide, somatostatin, terlipressin. All bleeds should be given antibiotics also. Antibiotic you can give, drug of choice basically is third generation cephalosporins like cefotaxime or ceftriaxone. What antibiotic do in bleed, you will ask, because it prevents the SBP and it help in preventing infection, which if infection bacteria are present, they can cause endotoxemia and vasodilatation, which can contribute to the bleed. So antibiotics are usually prescribed. Transfusion to hematocrit value of 24%, I told her keep it around 8 gram hemoglobin. Upper GI endoscopy should be done within 12 to 24 hours, and variceal ligation or sclerotherapy should be done. If bleeding is controlled, if then give the secondary prophylaxis for the bleed. If the bleeding is not controlled, you can go for TIPS, that is transjugular intrahepatic portosystemic shunt. It is again go through the interjugular vein, cannulate the hepatic veins, puncture the portal vein from there, and put a stent. So whenever you put a stent, you bypass the sinusoid. Once you bypass the sinusoid, that pressure in the portal vein will be released. But now the blood is directly going into the systemic circulation. Got my point? The blood is now directly bypassing the sinusoids of the liver. So patient, all blood which is coming from the gut is directly going to the systemic circulation, bypassing the liver. So patient can land up in hepatic encephalopathy after a TIPS. So TIPS is contraindicated if the patient has history of hepatic encephalopathy. Otherwise, TIPS is a good procedure to reduce the HVPG. It is used in refractory ascites, it is used in refractory bleeds, and so on. So once you give beta blocker and EVL, the patient is still having recurrent bleed, then of course you do TIPS or otherwise transplant the patient. Now next, let's discuss ascites. It is the most common complication of decompensation in cirrhosis. Every year 5 to 10% of compensated cirrhosis will develop ascites. Of course, it impacts the patient, like patient working and social life. Patient have distension of the abdomen, usually associated with pedal edema also, and it frequently leads to hospitalization. Patient can't move around that much and require chronic treatment. It is poor prognosis also. 5-year survival once ascites develop is around 30% only. Cause why ascites is formed, basically still a theory, nobody knows perfectly why it occurs. Basically increased nitroxide vasodilatation, real sodium retention, then RAS activation, overfill intravascular volume, and ascites is formed from the liver surface. Nobody knows the exact cause till now, but still they are in theory. And ascites is the most common. Cirrhosis is the cause of 80% cause of ascites. In patient evaluation, you can take other causes of ascites are always there whenever you are medicine. Cardiac causes, renal causes, there can be generalized anasarca. All those causes you have to rule out. Don't, whenever you see a patient of ascites, don't jump on the cirrhosis. But cirrhosis is the most common. So whenever the patient come, you take history, physical examination, abdominal ultrasound, lab investigations, and make a diagnosis. Ascites, clinically you can grade mild, moderate, or large ascites. Mild means only by ultrasound you detect. Moderate means you can manifest clinically, like all your signs, clinical examination that can be shown. Large or gross ascites provoke marked abdominal distension. Like in our MBBS time, people used to teach this puddle sign and all those things. But I usually don't feel for that, because better to get a ultrasound. Now ultrasound is available almost at every place. Those were the days when ultrasound used to be a luxury. You get to have a long date. Now you get so many information from the ultrasound. So whenever ascites is there, you can tap the ascites and see the whether it is a high sag ascites or a low sag ascites. Sag concept. First see this. So you see serum albumin, ascitic fluid albumin in the same sitting. Like you take the ascitic fluid and take the blood also. Do the serum albumin, ascitic fluid albumin, and decrease the serum fluid from the ascitic fluid. So high sag ascites is usually due to portal hypertension, basically. Low sag ascites, earlier concepts of transudative or exudative ascites now are outdated. We only talk of high sag ascites or a low sag ascites. High sag means due to usually portal hypertension, like alcoholic hepatitis and cardiac causes, means cirrhosis and cardiac causes basically. Low sag ascites is usually basically what used to be earlier exudative, like patient have inflammation like tubercular ascites, patient have malignant ascites, pancreatic ascites, nephrotic syndrome. All these are having nephrotic syndrome. Remember, pleural effusion में it becomes transudative, but ascites में it is low sag ascites. Okay, so whenever the ascites comes, you always test for sag. Color you have to see whether it is bloody, milky, dark brown, transparent, clear, cloudy yellow. You have to always see the WBC count and polymorphonuclear count. Uh, leukocyte count is the most important. More than 250 always may most of the time indicate a infection, and less than 250 usually are not there. So whenever less than 250 and high sag and total protein is low, then it is a cirrhotic ascites. But if the total protein is high, whenever the total protein is high, you always think of the cardiac cause of ascites. So cardiac causes of ascites also have high sag, but they have a high total protein. Low sag, low protein is nephrotic ascites. When the polymorph nuclear means leukocytes count is more than 250, high sag, you suspect the SBP. If it is a low sag, secondary bacterial peritonitis. Secondary bacterial peritonitis, like some perforation has occurred, and usually you see rigidity and all those things. Like biliary ascites can also occur, or appendix has ruptured, and that has caused leak of fluid. Colon has ruptured, small bowel has ruptured, and that can cause fluid collection, which is ascites there. Malignancy also can have this low sag ascites, and tubercular also have low sag ascites. So whenever the ascitic fluid infection is there, you always send for the culture also. So you can have fever, abdominal pain, abdominal tenderness, rebound tenderness. Patient can have encephalopathy also. So patient can have a spontaneous bacterial peritonitis when the single organism is there in the culture. If there are multiple organism, bacterial ascites, culture negative, neutrophilic ascites means you don't grow anything in culture. So most common causes are SBP or CNNA, Kanna. Secondary peritonitis usually due to some secondary cause like perforation or polymicrobial bacterial ascites. So how you treat the ascites, fluid infection. They are most important thing. Whenever a cirrhotic patient comes with ascites and fever or even renal failure or hepatic encephalopathy, always do tap and rule out infection. That is the most important thing. So they are easily treatable. 5 days of IV antibiotic, usually third generation cephalosporin, like cefotaxime 2 gram every 8 hourly, or ceftriaxone you can give. For prevention, once the SBP occurs, most important thing is spontaneous bacterial peritonitis. Once the SBP occur, you have to always give prophylaxis to the patients. Like you give norfloxacin 400 mg once daily until death or liver transplant. If the patient has GI hemorrhage also, then you have to give bleed. Then also you give norfloxacin for 7 days during those time that I told. What is refractory ascites? Refractory ascites means ascites that cannot be mobilized or the early recurrence of which cannot be satisfactorily prevented by medical therapy. Means once you give, it can be of two type. It can be diuretic resistant or diuretic intractable. Diuretic resistance means that cannot be mobilized or the early of which can not be because of lack of response to sodium restriction and diuretic treatment. Patient is not responding to the treatment. Second, diuretic intractable means patient can respond to diuretic this thing, but once you increase the diuresis, kidney injury occur or side effects of diuretic occur. So you can't give diuretic basically. So it is of two types. So in grade 1 or mild ascites, you just do sodium restriction. Grade 2, you correct the sodium imbalance. Sodium restriction means you ask the patient to take sodium less than 2 gram per day or common salt like sodium chloride less than 5 gram per day. So it is very difficult to explain to the patient that you have to take less than 5 gram. You can't measure it. So basically you can don't take any extra salt except the curry. So जो सब्जी खाते हो उसके अलावा कहीं पर भी नमक नहीं डालना. So basically that comes down to around less than 2 gram of sodium. You can give mineralocorticoid aldactone. You can start 100 milligram per day and then increase up to the 400 milligram per day. You can also add furosemide or torsemide वगैरह जो सब add कर सकते हैं. Usually we add in the like for every 100 milligram of mineralocorticoid aldactone, we give 40 milligram of furosemide. So that can be given. So diuretic therapy you cannot give when the patient is having overt hepatic encephalopathy or any renal injury. Then you can can't give. So basically you have to give a low sodium diet, measure the urine sodium, whether the patient is means whenever there is no response, you measure the urine sodium by potassium and see whether the patient is having taking proper diet or not. You have to all continue NSAID, ACE inhibitor, ARB, beta blocker, and if still ascites persist, you can add midodrine. It is now available in India, a little bit costly, but you can try in refractory ascites. Then if the ascites still persist, then you can do either repeated tips or transplant. Comes to 3T. Either keep on tapping, ask the patient to come, get tap, and then it go, or you can have it tips. Tips you can't do if you are hepatic encephalopathy, but the best thing is to get a liver transplant. But unfortunately, in India, in spite of our huge population, most of the people are not doing organ donation, and we have a shortage of liver. So the most common liver transplant in India is from the live donor. It's not from the dead donor. Next complication is acute kidney injury in cirrhosis. It occurs in 15 to 25% of hospitalized patients. It is usually by some precipitating event. Like I was treating ascites, I have increased that diuretic dose so much that the kidney dysfunction occur. I have done a LVP around 5 to 6 liter, but I have not replaced with albumin. GI bleed has occurred or spontaneous bacterial peritonitis. These are the most common causes of AKI in cirrhosis. So basically, whenever there's cirrhosis, portal hypertension, inflammation, bacterial translocation, and all those occur, so there is a splenic and peripheral vasodilatation. So there is a decreased circulatory volume. Whenever there is a decreased circulatory volume, the RAS get activated, and there is sodium and water retention. So basically, there occurs a renal vasoconstriction. When the renal vasoconstriction occur, the GFR will be reduced, renal perfusion will be reduced, and it will cause a hepatorenal syndrome. ACE, ARB, and SAID increase this renal vasoconstriction. Diarrhea, diuretics also decrease this circulatory volume and contribute to the kidney injury, large volume peristalsis, all those things. So AKI staging, multiple criteria are there. Rifle criteria, I don't think you require at this stage. So what are the diagnostic criteria for hepatorenal syndrome? Presence of cirrhosis and ascites. No improvement in serum creatinine after 2 consecutive doses of withdrawal of diuretic and plasma volume expansion with albumin. Absence of shock. Exclusion of recurrent or recent use of nephrotoxic drug. exclusion of parenchymal liver disease. Basically, you rule out all other causes of kidney injury, then you can say it is a hepatorenal syndrome. So how you manage a hepatorenal syndrome? You can measure, you can prevent variceal bleed. You can use pentoxifylline for severe alcoholic hepatitis. Pentoxifylline earlier in a trial in 2003 was shown to prevent renal injury in alcoholic cirrhosis, but the recent trials have not shown any good benefit. So people have started stopping using that. You should avoid over diuresis. You should not use any nephrotoxic drugs, and you should give the patient have SBP prophylaxis once the SBP occurs, because otherwise the patient can develop renal injury, and HRS is basically quite serious and high mortality. So when the HRS occurs, you should stop all nephrotoxic agents. You should give antibiotic if there is any infection. IV albumin 1 gram per kilogram per day. You should be given at the presentation, and then you should give vasopressor therapy like terlipressin. Terlipressin is available in India, not available in USA, but still it works well. Then you can give midodrine or octreotide. Still not available, then you can give noradrenaline infusion and evaluate the patient for liver transplantation. But it has very high mortality. Now coming to the hepatic encephalopathy, that is another manifestation you see in the cirrhosis quite commonly. It occurs in 50 to 70% of patients with cirrhosis, and it is also a poor prognostic marker. There are three types of hepatic encephalopathy, we can say type A, B, C. A is associated with acute liver failure. B is associated with, you can say, portosystemic shunt, and type C is associated with cirrhosis. B, you can remember bypass. Shunt basically means you are bypassing the liver, like in TIPS. Type C is cirrhosis. Type A is acute liver failure. The other classification, you can say it is covert, persistent, or episodic HE. Covert means it's a minimal hepatic encephalopathy that you can diagnose only by doing some specialized test, or it can patient can have overt HE like mild HE, treatment dependent, severe HE, or sometimes spontaneous HE, precipitated or recurrent HE. So again, why the HE occurs? Because of portosystemic shunting, there is increased blood ammonia level. I told you, because there is vasodilatation, portal hypertension, multiple collaterals have forms. So sometimes the collaterals are so much the blood bypassing the liver becomes too much. So the blood ammonia level, which was metabolized by the liver, directly reaches the brain. So it causes brain edema, astrocyte swelling, and altered brain glucose metabolism that result in hepatic encephalopathy. It is usually graded into 0 to 4 stages by West Haven criteria we commonly use, but I don't think we require this. Once the patient is flapping, you can say asterisk is when the present. It is a grade 2 type of HE. Grade 1 is personality change, means patient is irritable, sleeping at means daytime, waking up in night, and minimal HE you can diagnose only by some exam test. So whenever there is a hepatic encephalopathy, you have to eliminate or correct the precipitating factors. Like if there is any bleeding, treat the bleed, infection, hypokalemia, any drug he is taking, dehydration, and you have to give measures to reduce the blood ammonia level. So how to decrease blood ammonia level? Ultimately, the ammonia is generated from the gut. So you have to give lactulose. Lactulose makes the gut acidic and decrease the ammonia, this thing. Rifaximin is quite commonly used. Rifaximin decrease is basically a antibiotic which is not absorbed systemically but act on the gut. So it sterilizes the gut, decreases the bacteria, so ammonia formation decreases. Lola you can give basically, but still not very helpful. Sodium benzoate decreases the ammonia through the urine. It is the one of the least studied drug because it is the cheapest available at all kirana store, pansari ki dukaan sab pe milta है, and can be used in He. Branch chain amino acid decreases the He, but the main pillars are lactulose and refractory. You have to take care of the nutrition in this patients. You have to give adequate amount of carbohydrate, protein. You should not, whenever the patient of hepatic encephalopathy, many people decrease the protein intake, but that in turn decreases the nutrition and causes other problems. So better to continue with your casein based or vegetable based protein. You can give branch chain amino acids and frequent small meals. Screen for vitamin deficiency. There are other complications also like hepatopulmonary syndrome and hepato portopulmonary hypertension. Portopulmonary hypertension is just like pulmonary hypertension in presence of a cirrhosis. Hepatopulmonary syndrome, basically you have shunts in the lungs where the this thing blood bypasses the alveoli. So basically you have decreased oxygenation. Treatment, nothing except liver transplant. So that's all, students. Let me see. Basically I don't know how this is thing. So I think I don't know how to interact with you people. Okay, so questions is survey again here. Okay, there are some questions here. Wait a minute. Yes sir, yes sir, yes sir, yes sir. Persistent PSC, I don't know. How does this ACLF differentiate from decompensated cirrhosis clinically? Okay, ACLF is a totally different thing than a decompensated cirrhosis. There are basically it's east versus west differences. West says whenever the West says whenever there is a acute acute problem in any cirrhotic patients, like the patient developed a renal failure, patient developed jaundice, patient developed SBP, that will be included in the ACLF. The East Society like APASL, EASL and ASLD, they are European and American. Their ACLF criteria is any acute decompensation in a patient of cirrhosis is ACLF. Here the criteria are a little more stricter, where you stricter, like you require bilirubin more than 5. Basically, the patient should have jaundice, encephalopathy, and ascites. If these three criteria are there, then the patient is more likely to have a ACLF, and it has a much poorer prognosis than decompensated cirrhosis. Is albumin still given in cirrhosis in HRS? Yes, albumin should be given for the first 48 hours so that the you can replace the volume and then see the response. Thank you, sir. Please repeat how we measure HVPG. HVPG means you can relate through the internal jugular vein, go to the hepatic vein. From the hepatic vein, you puncture to the any sinusoid or portal hypertension. There you have a balloon there and a manometry there. Manometry is associated with there. So first you inflate the balloon and measure the wedge hepatic vein pressure. Wedge hepatic vein pressure, you after inflating the balloon, you can measure only the sinusoidal pressure basically. You can't measure the hepatic vein pressure. So first you measure the sinusoidal pressure, then you deflate the balloon, and then the free hepatic vein pressure can be measured. So basically you have to divide minus wedged hepatic vein pressure minus hepatic vein pressure. And if you want some video, you can see the YouTube. So can there be jaundice in cardiac causes of cirrhosis? Yes, acute Budd-Chiari syndrome present as jaundice and ascites. Okay, anything else? I think these are all the questions. I have one more class that was planned basically earlier on 7th of this month, but I missed that class because I didn't get the information in the right time. On that day itself, I came to know that I have a class. So if you people agree, we can plan that class next week, anytime. Okay, if you are interested, you can say that class was the topic given to me was inflammatory bowel disease. Okay, so shall I stop? Okay, thank you. Sorry for the morning session. Okay, bye. Stop sharing option. Okay, stop sharing screen.